Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. All right, hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour. Spark Live, as always, is where we gather each Wednesday to curate and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we are live, I do want to remind everyone you do have the opportunity to type questions into the question box at any time. We'll check for questions throughout the session, so don't feel you need to wait until the end. Just type them in as you think of them, and they can be questions and or comments, whatever you'd like. Just go ahead and type those in there. And always feel free to share your thoughts on Twitter, and if you do, be sure to tag us at Child Health Can. And quickly, before we start, this is just about time for the Children's Healthcare Canada annual conference this year, being held on December 8th to the 10th, which feels like it's literally almost 2 weeks away, not even. It's being held here in Ottawa, Ontario, at the Westin Hotel, and the registration, of course, is still open. Lots of time to register. The program's up on the website at conference.childrenshealthcarecanada.ca, and hopefully we'll see lots of our Spark Live audience that we meet with virtually every week. Hopefully we'll see some of you in person there. And today we're talking about managing pain and distress in children undergoing brief diagnostic and therapeutic procedures. And before we get to that presentation, I did want to briefly mention SKIP, or Solutions for Kids in Pain. It's a great opportunity for us to actually talk about, for me at least, to talk about some work that I'm actually involved in, instead of only coming here every Wednesday to bring other people to talk about the great things they're doing. SKIP, as many of you know, is one of the last NCEs, or the Networks of Centers of Excellence in Knowledge Mobilization, that were funded by the Government of Canada. It's a 4-year initiative, and SKIP is co-led by Dr. Christine Chambers at Dalhousie University and myself here at Children's Healthcare Canada. And SKIP was created to address that often 17-year gap from the time that research is published to the time it has an impact in clinical practice and benefits children and families. And we're building on the work that Dr. Chambers started back with the It Doesn't Have to Hurt initiative a few years back. Many of you may be familiar with that. And that initiative connected researchers with the latest evidence in pediatric pain, and connecting them with patients, families, and clinicians. They leveraged a number of traditional and non-traditional media partners like parent magazines and mommy bloggers, and they did other creative things to use social media and other creative ways to mobilize knowledge. So continuing that work and building on those relationships, we're also now engaging hospital administrators and other partners at the system level to really work all this evidence all the way through to widespread implementation of best practice on a national scale. And to do that, like some of the interesting things we're doing at SKIP are continuing those creative knowledge mobile activities that Dr. Chambers started a number of years ago, like this webinar series and lots of activity on social media, but also now working with groups like CFHI, who are experts in organizational readiness and implementation of new innovations. And they're actually partnering with us at the Children's Healthcare Canada conference with a workshop on December 8th. You're welcome to join that workshop. Again, you can register through the conference site on the Children's Healthcare Canada website. We're also working with Health Standards Organization to develop an accreditation standard for acute and chronic pain management in hospitals. So lots of other exciting things, and many of you are welcome to communicate with us and get involved. We're really just getting started. We're about 6 months into our activities. We had a series of launch events across the country starting back in April. Some of the information is up at the SKIP website at kidsinpain.ca, but we're still in the process of completing our actual website. This one's actually just a placeholder, but there is some information there. SKIP has a regional hub structure with an Eastern hub, an Ontario hub, and a Western Canada hub. So, and there will be more information on the website coming soon about how your organization can get connected to SKIP through that hub structure. We also have an affiliate hub program where other hospitals are joining in order to play a more substantial role in pediatric pain. And we were excited to welcome BC Children's Hospital as an affiliate hub just last month. So again, lots of great things happening in the world of improving pediatric pain management. And as a knowledge mobilization network, today is a great opportunity to bring in some colleagues from the Canadian Pediatric Society to share some of the work that they have produced related to a clinical practice or a practice guideline related to pain management in children. So to tell us more about that, it's my pleasure to welcome Dr. Evelyn Trottier and Dr. Samina Ali to the podium. Dr. Trottier is a pediatric emergency physician at CHU Saint-Justin in Montreal. And she is also a clinical assistant professor at the University of Montreal. Her primary interests are procedural pain management and knowledge translation. And she participated in the creation of the procedural pain management toolkit project that was part of Children's Healthcare Canada, or at the time CAPC, in our community of practice, where we created that pain management toolkit. And joining Dr. Trottier is Dr. Samina Ali, who's a pediatric emergency physician at Stollery Children's Hospital and a professor of pediatrics and emergency medicine at the University of Alberta. She's an expert in all things pain management when it comes to dealing with kids in the emergency department, but also, more importantly, she's the hub lead of the Western Canada hub that's part of SKIP. And she was also co-chair of that pediatric pain community of practice that was part of Children's Healthcare Canada's work a while ago. And the pain toolkit that Dr. Trottier and Dr. Ali contributed to creating is still on our Knowledge Exchange Network. You're welcome to go check that out at ken.childrenshealthcarecanada.ca. So without any further ado, it's my pleasure to hand the virtual podium first off over to Dr. Samina Ali out in Edmonton. Over to you.
Super. Thank you so much for that kind introduction, Doug. We're so excited to be here to talk about this new statement just released this month by the Canadian Pediatric Society. While, of course, the information within it we feel is super important, probably even more important than that is the fact that it raises to a national standard level almost the fact that children's pain matters, and that is an incredible step forward for children. So with that, I'll move forward to talk to you about flu season. So it's flu season, and looking at these lovely people on the slide, I was struck by how much happier they look than when I go to get my flu shot, because even as an adult, I know it's a cringeworthy experience for me, and certainly don't love it. And we are adults. We have an understanding of the importance of it. We have an understanding of the temporary nature of this discomfort or pain that happens with it, and still we tend to have some sort of negative feelings or stress about having it. The vast majority do anyways, so it seems when you look at the literature. So now imagine if you're little and you are having almost 24 pokes before the age of 16 years, and this is just routine childhood immunizations and flu shots. So flu shots alone would be 16, and then routine vaccinations are close to 20. So I think I may have even underestimated. We're probably closer to 36 if you're getting your flu shots as well. And unfortunately, what happens is that if children have negative childhood experiences around these vaccines, as some of these pictures might suggest, then that can develop into a fear of needles or a needle phobia, which can then go on to create quite a bit of challenge for that child, their family, and the healthcare providers that will care for them, not to mention the emotional and psychological impact of it, which we'll talk about in just a moment. So I've been thinking about this a lot recently in the context, or thinking about treating children's pain in the context of needle phobia. And so I sort of went down this rabbit hole of trying to understand how needle phobia fits into this. And at first I thought it was not that common, but when I started doing some digging, it's actually much more common than I had realized. So fear of needles alone. So this is not a true phobia, but that discomfort, that dis-ease, that wanting to avoid it if at all possible. More than 2/3 of children and youth endorse having fear of needles when you look at the literature in terms of surveys that are out there. And up to 33%, or 1/3 of children and youth with type 1 diabetes endorse fear of needles. And that one kind of broke my heart a little bit, because for the time being, type 1 diabetes is still an illness that requires pokes. It requires needle sticks and injections, and 1/3 of them endorse this fear. 1 out of 5 adults also endorses a fear of needles. And then when you get into the true diagnostic definition of needle phobia, up to 10% of the population is endorsing that. And there are risk factors that make you more likely to develop it. So not everyone who's going to receive childhood vaccinations, for instance, or have blood work will develop this. But if you have certain family histories or life events, it can make you more likely. The problem is, as healthcare providers and administrators and people who care for children, we don't have a good way right now to predict who will develop needle phobia. And I think that is the biggest argument for why we should attempt to minimize or one of the biggest arguments for why we should attempt to minimize and prevent pain and distress with painful childhood procedures as much as possible, because we can't predict who's going to run into trouble. So we should have a proactive, preventative approach. In a nationally representative sample in the U.S., almost 1 out of 5 adults did not obtain their pneumococcal vaccine, and same for tetanus vaccine, because they dislike their needles. And these are significant illnesses that are preventable, vaccine preventable. And 1 out of 5 people are saying they're avoiding them because of their fear of needles. Similarly, even within healthcare providers, we're seeing the same concerns. So in a survey of 100 US physicians, 70% indicated that a fear of needles was a contributing factor to not obtaining a tetanus or influenza or pneumococcal vaccine. So not that 70% of them didn't get it, but of those who didn't get it, 7 out of 10 of them endorsed worries about the needle as a reason. Nope. So what does untreated pain mean for our children? It means longer healing time. And the next 5 or 6 slides just sort of reminds us of what this means for children and for their families and for us as healthcare providers and administrators. So in the most administrative of lights, if you will, if untreated pain means longer healing time, that means longer hospital stays, which means more blocked beds, which means more people languishing in an emergency department waiting for a bed, or delayed surgeries. So it has real implications for our flow and safe care that we can provide in the department. But of course, that's not to underplay the importance of what it means for each individual person. So as I said, longer hospital stays. If you are healing more slowly, you are recovering more slowly, you're ambulating less quickly because of your pain, you end up staying in the hospital longer. It means more complications, and we know this because untreated pain leads to higher cortisol levels, higher stress hormones, and those hormones are known to impede healing. And so more complications, more infections type of thing can happen. When children don't really get used to needles, if you will, they can learn to become anxious about needles, which can lead to a fear. Or if we give them good coping mechanisms, good distress and pain minimizing strategies, they can learn to be okay with them. But the greater distress during a needle procedure means more pain and distress during future procedures. And so not only are we making it hard for our child in front of us today, we're actually setting up our colleagues for troubles in the future. So if I don't do a good job today in the emergency department treating a child and preventing and minimizing pain as much as I can for their IV insertion, for instance, 6 months down the road when it's time for them to get a routine vaccination, it may be extremely distressing for them. Or a year from now, when they need more blood work, they will come in kicking and screaming. And we've met this poor mouse, the child who you walk into a room with your best smile and they just start screaming and saying, no needle, no needle. And you haven't touched them. And you know someone has unfortunately created a situation where they were terribly afraid prior to your walking into the room. And these negative experiences during childhood don't necessarily end in childhood. They can lead to avoiding needle procedures in adulthood as well. When children don't get adequate pain relief during a painful procedure, subsequent procedures will not only be stressful, they'll actually report more pain with the procedures, regardless of the analgesia you received. So now going back to that example of me ordering and drawing blood work in an emergency department, if I don't optimize the situation for the child there, the next time they come in to get blood work, they will report higher pain and report their analgesia as being less effective, even if someone tries to do it right the next time. Infants and children who undergo repeated painful procedures are more likely to avoid health care as adults. So now you have people who are sick, who have appendicitis, who are sitting at home because they just don't want to go in because they're afraid of the painful things that might happen to them. And we know that certain conditions, the longer you stay at home, the more likely to run into complications, for instance, perforating your appendix, for instance. And healthcare avoidance includes, as we've been talking about, avoiding vaccinations. And Canada, unfortunately, has gone from being highly vaccinated to lower vaccinations over the last decade. And we're losing our herd immunity because of this. And pain is, or avoidance of pain, fear of needles is contributing to this. So even if we could overcome that one piece, it would be incredible how this might influence our vaccination rates within the country. It is an American source that I found, but one source did say 10% of people who are avoiding routine vaccinations endorsed pain as the reason. So if you believe that statistic, addressing the pain around needles in childhood could potentially increase our vaccination rates by 10%. So this is not just, and I say that in quotation marks, about feelings and emotions. This is changing the actual brain wiring for babies. So having procedures with poorly managed pain can actually have widespread effects on brain development when the brain is developing, such as for neonates, infants, and truthfully, up until the age of 25 years, as I'm now following the cannabis literature, and it's becoming quite clear that a brain still is growing and finalizing until the age of 25. Of course, the effects are more pronounced in the younger years in the context of untreated pain. The neurodevelopmental problems that can happen include cognitive, language, visual, and perceptual, motor, attention, and learning deficits. So it's quite broadly affecting their overall development. There's a few small studies out there that have actually looked at EEG changes during and after painful procedures and showed that the actual wiring or the neural response to pain changes on EEG with people when they have untreated or recurrent or chronic pain. And then most recently, I've been seeing some literature emerging now about how untreated pain in infancy and childhood affects intelligence or IQ measurements. And the cumulative number of skin breaking procedures from birth to term are associated with lower IQ and more anxiety and depressive symptoms at school age. And this is after controlling for acuity and how sick they were and how long they spent in ICU. So there's some significant impacts to not treating children's pain. Because sometimes we hear, well, it's being nice. It's not being it's not really healthcare. And I think I feel like I'm preaching to the converted, I suspect, on this webinar, but I think that is, these last 5 or 10 minutes have really consolidated for me, and I hope for you, the fact that this is not being nice, this is providing proper and responsible healthcare. So at this point, what I will do is switch gears a little bit and hand it over to Dr. Trottier to talk about the National Canadian Pediatric Society position statement on the treatment of minor medical procedure-related pain and distress. Again, this marks such an incredible step forward for our children to now have this national statement to draw upon. And with that, I'll hand it over to Dr. Trottier.
Thank you, Samina, for this very interesting introduction. So as Dr. Ali explained so well, taking care of pain and distress while doing a procedure in a patient, even more in a child, is very important. This is why we wanted to propose a CPS statement on this important topic. But how can we take care of procedural pain and distress properly? What are the evidence-based approaches that we can use? This is what we have focused when we were writing this statement. So in our statement, we overviewed on how to reduce pain and distress related to a mainly minor but painful procedure. We reviewed and described a simple evidence-based strategy that can be used in clinical practice and that healthcare provider can integrate easily in their patient care. You can change slide, Samina, thanks. So for each procedure, clinicians can use the minimally invasive approach, and this should be promoted as some less painful procedures are sometimes available. For example, when a clean urine test is required in a small baby, a clean cat's urine technique, the new method, can be tried, avoiding a painful urethral catheterization or a suprapubic aspiration. When a more painful procedure is necessary, we suggest to combine simple pain and distress minimizing strategy to improve the patient care, as well as the parent experience and even the provider experience, because we all want the child to be comfortable and to not cry so much under our care. So let's talk a little bit about some examples that we are proposing in the CPS statement. Here is Tanya and Iris requiring either an IV line for Tanya and for an antibiotic administration and some blood tests for Iris going to the emergency department. To reduce their distress, there's different physical strategy that can be used. When we talk about physical strategy for different painful pathology or procedure, this can include, for an example, in a patient that has a burn, to cool and dress his burn more rapidly to improve his comfort, or to immobilize a suspected fracture early to reduce the movement of the broken bone. For a needle procedure, taking care of some physical comfort means to try to keep the patient seated as much as possible. So for Tanya and Ulysse, having the child to be in a seated position, comfortably held by their caregiver, to be on their lap for the youngest one, can reduce their distress and improve the child comfort. It can also help to improve the procedure for the healthcare provider in reducing the child's movement. Some physical strategy can also be used in newborn, if you can look on the next slide. So in young baby, you can hold and rock the baby to lower his pain and distress score related to painful procedure, and this has been shown to be effective in small babies and neonates. You can use the skin-to-skin technique on parents, known as the kangaroo care, to keep the baby more comfortable during a needle procedure. Swaddling can also help the baby to be more comfortable. For some procedure, you can also ask the mother to breastfeed their child prior and during the procedure, and this has been shown as well to keep the baby more comfortable. But for some procedure, breastfeeding cannot be possible, as let's say for a lumbar puncture, where it will be quite difficult. So for those procedures, sucrose or sugary water is proposed. Sucrose should be given before and during the procedure, and it is more effective if you use it with non-nutritive stocking, such as using it with your pacifier. You can do your own homemade solution, mixing 1 teaspoon of sugar and 2 teaspoons of water. There's as well some psychological strategy that has been studied to reduce pain and distress in related needle procedure. The most studied psychological strategy is distraction, as you can see on the picture on the other slide. Here, exactly. So you can see those 3 little kids having fun during their procedure, being distracted by their environment. To do so, you can use colorful wall and decor, giant seek and find game on the wall and roof that can be created to reduce the anxiety related to the environment. You can also use a smartphone of the parents to make the child listen to music, to look at some videos, and parents can read stories to the youngest one, or you can blow bubbles for them. You can also use more complex active distraction in older children, such as playing at some video games or using virtual reality distraction that has been shown to be interesting in some studies. For those older child, the most effective distraction will focus on their empowerment, asking the child to give his preference in terms of the distraction tool. Moreover, it will be interesting to engage them in a non-procedural related conversation to help to shift their attention away from the painful stimulus. Some relaxation technique can also be used in youth, asking them to take deep breath. So this is different distraction or relaxation strategy that can be used. Of course, as you can see on the other slide, there's some pharmacological strategy that can also be used. So let's say for needle procedure, you see here Sarah that needs to have some blood tests, and you can propose her some topical anesthetic to reduce her pain. You can use those cream prior to venipuncture, IV insertion, lumbar puncture, immunization, and those cream reduce pain for the child, but they also help the healthcare provider because they reduce the procedure time and increase the success of the procedure on first attempt. So they are cost effective and very interesting, which is very interesting for us as well. Some newer cream are even more interesting because they can be effective faster in 30 minutes. I'm talking about Maxilin or Ametop, and this is much more interesting in the emergency department than the 60-70 minutes that takes the EMLA cream. However, those cream do not seem to be effective for finger prick or for heel length in babies. And talking a little bit about heel length, some studies have shown that even without cream or sucrose, heel lenses can be more painful than venipuncture. So when you have just one blood test to do to a baby, maybe it's more cost effective to do it just once using a venipuncture, and it will be less painful for those little ones. For urgent needle procedure in a patient older than 3 years old, a cooling spray called Pennies can also have also shown interesting results, reducing pain in children and improving the procedure for the healthcare provider as well. So now let's talk a little bit about lumbar puncture. You can see Stuart, Annie, and Sarah that require a lumbar puncture as part of their investigation. Unfortunately for those patients, many studies often report that we poorly manage pain and distress when we do a lumbar puncture in children. However, we know that taking care of the pain while doing this procedure can also improve the procedural success. So you can combine the physical and psychological strategies that we have already described, and you can use as well the topical anesthetic that we already have discussed. And on the top of that, we suggest to add lidocaine infiltration to make the patient more comfortable. There's an interesting gas that can be used in patients older than 2-3 years old, the nitrous oxide gas. That is very interesting to reduce the anxiety of the child and to have some analgesic effect as well. This gas has very minimal side effects, and its main advantage that it has very rapid onset in 3 minutes and rapid offset of action. So this can be an interesting option. So now let's see Xavier and Tommy that both present after falling on a table corner and presenting with clean facial cuts that will need to be repaired. A topical anesthetic can also be used prior to laceration repair. It's called the lead gel, lidocaine, epinephrine, tetracaine, and it is very effective to reduce pain during the repair, and it helps the healthcare providers in gluing or stitching the laceration by reducing the bleeding of the wound. Moreover, most of the laceration in the face are clean and neat and can be glued by medical glue, avoiding the frightening stitches. In the statement, we offer some tips as well when a laceration needs to be stitched. Now we have Sarah and Samir that both fell from the monkey bar and that present to the emergency department with their swollen elbow. We are suspecting a broken bone for both of them, and even for Sarah, this fracture seems to be displaced at our examination. So they will both require an X-ray. Of course, fractures are obviously painful, and pain for displaced fracture can be excruciating. X-ray is certainly one of the more painful part of the care of Sarah and Samir. So to reduce their pain, you can use ibuprofen, and in a nice Canadian study, it appeared to be superior to acetaminophen to alleviate pain related to different musculoskeletal injuries, and it seemed even equivalent to oral morphine in some studies. For severe pain, like for Sarah with her suspected displaced fracture, intranasal fentanyl seems to be quite interesting to reduce quickly the pain related to her injury. This can reduce the pain of Sarah and Samir going to X-ray until they receive their definitive care, either a reduction of their fracture under sedation or immobilization with a plaster cast. So we have all those useful tools that have been studied. We review the evidence behind all of those strategies that we were reading in the literature. But this now to be applied now into practice as part of an essential component of the care of the patient. How can we make this happen in our hospital? How can we include those strategies in our department? How can we increase their use in our care and in our for the different healthcare providers that work with us? So Samina will propose use some tips and resources that are useful in the last part of our presentation. Back to Samina.
Great, thank you so much, Evelyn. So yeah, this is sort of to close out our session this morning. I wanted to remind us of some of the resources and tools we have within Canada that can help make this applying some of what we've talked about this morning a little bit easier. So first and foremost, Doug had mentioned Children's Healthcare Canada's Pain Toolkit. So this was an incredible collaboration of a community of practice for almost 5 years to create multiple toolkits to allow us to provide content to make it easier to make change. So that if you are listening today and saying, you know what, it's time we had and if you don't already, it's time we brought topical anesthetic to all of our places where children might have skin piercing procedures. But what does a policy look like? What might the content in a toolkit look like? What teaching tools or PowerPoint presentations can I use? What evidence can I show my team to convince them that this actually works? Well, if you went to the Children's Healthcare Canada Pain Toolkit for topical anesthetics, you would find examples of policies such as these ones. The middle one is with topical anesthetic. There's ones for intranasal fentanyl, for sucrose drops. There's a toolkit for each of those options. You would also find, if you're looking into, for instance, the chronic pain toolkit, examples of where you can find pain clinics for children, because prescribing specific treatments in those toolkits wouldn't be possible. But the needs of those patients and those families, we try to address through different resources. But back to the acute or procedural pain, you can find videos that you can share in your waiting room, for instance, about empowering and teaching our families what to expect and what they can do. There's exemplars of posters that can be put up in your department, or handouts that can be given to families. And then for those who like to have all the original evidence, we've put lists of the original literature that supports the toolkits. Each of these toolkits is wholly and fully supported by synthesized, filtered level of evidence, so systematic reviews to help make sure that what we endorsed was already wholly proven in the literature. The only caveat to that would be intranasal fentanyl, which, while the evidence isn't quite as mature, is so broadly used, and we've received a lot of feedback from the Children's Healthcare Canada partners that they want, organizations that they wanted information about it. So that one is included with a lower level of evidence than the rest. It's another resource, Solutions for Kids in Pain, which you've already heard a little bit about this morning, but this is an organization whose sole mission, in the simplest of terms, is to improve the care for Canadians by improving pain care for children. So if you have a challenge, something you're trying to address, a question, reach out to SKIP. If they don't have the answer, they will find someone. This is a growing network of people who care about children's pain. And as you listening to this call, you would be completely welcomed and highly appropriate to join this network as well, as you see fit to be in the loop for information that's forthcoming. But if you find yourself trying to make a change to better treatment and distress for children's pain, and you're stuck, reach out to SKIP, and there's probably someone who might be able to help you out there. Just wanted to let you know there is a video online, a 2-minute video. We've put the link in the slides, which are available to you if you wish to just have sort of a little synopsis of what SKIP is about. And if you prefer, there's email, Twitter, and website where you can reach out to, and it takes about 3 clicks to register yourself to receive the SKIP newsletter. And the SKIP newsletter will keep you in the loop as to what's happening and what information is being shared. Then there's TREKK, which is another knowledge mobilization network translating emergency knowledge for kids. And for any of you on the call who take care of children in acute or emergency presentations, this resource is tremendous. You can sign up to receive their newsletters. They have a website, but they now also have a free app. So you can just go to an app store and download the free TREKK app, and then it will give you an interface of bottom line recommendations, which are 2-page summaries of the best evidence for whatever you're concerned about that might have an emergency presentation, plus podcasts and resources. And of course, they cover topics like asthma and croup and diabetic ketoacidosis, trauma, etc., because these are all emergency presentations. But they also have resources specific to pain, both presenting pain due to illness or injury, as well as procedural pain like we've talked about today. And it is almost entirely aligned with this CPS statement that was just released. So you'll find the exact similar information presented in a slightly different way. So there's things like these videos, how to help your child when they're getting a needle poke, which are family facing. So it's for children or families to watch. But you will also find best evidence repositories. So if you want to go in and look at all the information that was used to create their bottom line recommendation, it's there. And to the right of your screen, you can see the first page of 2 relating to procedural pain. So in this particular instance, TREKK has taken the information and organized it by procedures. So if you're thinking, wow, I need to do a lumbar puncture, what are all my options? It's divided in this document by procedure, which is a nice way to think about it. At the end of the day, untreated pain affects everyone. It affects from, of course, the child who is in front of us requiring the procedure, their family, the healthcare providers, and it makes our job as providers more difficult and more distressing. We didn't get into it very much today, but there is a significant body of literature talking about the distress that that healthcare providers feel when they don't feel they've treated pain well for a child. So it is affecting everyone in that room and beyond. Managing pain and distress in children saves money in the most tightest and most sort of a sterile of interpretations, but more importantly, it keeps people healthy throughout their entire lives. So there are emotional, psychological, moral reasons to do this. There are also some very tangible healthcare outcome and monetary reasons to do this as well. So the reason I raise this is that depending on who your audience is, you may modify how you pitch these changes to improve children's pain. And if you need information to back up your statement, it is out there and available. So at this point, I think Evelyn and I will stop speaking. Thank you so much for your time and attention. And we'd be so happy to take any questions anyone might have.
All right, thank you. Great presentation. I mean, you really highlighted a lot of the specific things that we can do that we know work. Things like skin to skin in infants and that sort of. I mean, really highlighted some of the things we know work. The issues around what administrators need, program managers, they need those policies and procedures to help them implement these practices and make sure they're done on a regular basis, make sure their staff are educated. So it's really, you really highlighted some things that TREKK, a fantastic resource right there with TREKK, especially for emergency departments. So really a great overview of some of the just a few of the resources that are out there, and there's many more. So thank you for a great presentation. As Samina said, opportunity to ask questions or post any comments. We do have a few questions in here. The first one that came in was just asking around, saying that staff are often reluctant to use topical agents, stating they are vasoconstrictive. Just wondering if this is true. Is there studies that prove otherwise, or what's the issues with topical agents and vasoconstriction, or any other issues that might be there?
Yeah, I'm happy. Oh, go ahead, Evelyn.
Let's go. No, go ahead. No. I'm sure we're going to say the same thing, so that's fine.
Yeah, so there has actually been that has been a perception, but when we've looked at the literature, we have not found any evidence that actually supports that specifically, and particularly when we're using the faster acting agents, there is no vasoconstriction with them. With the EMLA, there is some minor vasoconstriction, but in terms of that affecting capacity to get the procedure completed, I don't think there's any evidence that actually says that. So there's a perception. The healthcare providers may be feeling like there's a disadvantage, but there's no evidence to back it up. And when you're using the shorter acting ones, they actually have no vasoconstrictive actions at all. In fact, they have the opposite. Evelyn, anything you want to add to that?
No, I totally agree with your comments. When you're using Maxlin and Hamitop, this is not a side effect that we've reported. And with all of those topical agents, this has been shown to improve the procedural success. So in any case, even for the vasoconstriction that can be related with the EMLA, if you're improving your procedural success, I think this is the most important thing.
And that actually, Samina, reminds me of when we did the hub launch out in Edmonton, an interesting story that came from someone from the audience that was attending that day, a woman who was a nurse in the public health sector involved in the vaccination program, had the unfortunate experience of having to take her child into the Stollery Children's Hospital. But while she was there, she learned about what proper pain management was, learned a lot of things that she didn't know just based on the way the treatment that she was given at Stollery and what great things they were doing to manage pain. She wanted to bring that back to her role in public health and start offering things like topical agents and EMLA, and was told by administrators that that's not allowed. And again, that this lack of clarity or these assumptions that there's a problem with this and a reluctance to allow what we know is probably best practice, a reluctance, and not because it's an issue of clinicians not having best evidence, it's an issue of administrative barriers that are preventing people. So that's really one of the things that SCIP is trying to do. That's why we talk about the various layers of clinicians and researchers and patients and families, but also engaging administrators so that we can reduce those administrative barriers to implementing what we know to be best practice.
Yes, and I think for the example that you're giving with a nurse that wants to use topical anesthetic in her practice, I think it's our role to promote standing order for nurses to use, so they don't need a prescription to use those tools as well, because nurses do so much procedure to child, so they need to have access to those strategies easily if we want them to use them more.
There was a question about where do we find the handouts. You should see a handout there's a little handout section that will allow you to download the slides, a PDF version of the slides that Dr. Trottier and Dr. Ali presented. You should be able to find that there, and they do have, as you noticed, all the links, the various links in the bottom right corner of those slides. So you should be able to download them from the control panel. And if you can't find them there, just let me know and we can always send them off to you. The next question was asking about any recommendations regarding intranasal ketamine. And why don't we start with you, Evelyn, and see any thoughts on intranasal ketamine?
We're doing at the moment a project in St. Justine with intranasal ketamine for laceration repair. We did a first dose finding study because we know that with intranasal fentanyl, it's very well absorbed by the mucosa, and it's almost equivalent to intravenous fentanyl. But for intranasal ketamine, the molecule is bigger, so it's not so well absorbed. So we need higher dose to be used. In the literature, you can find those between 3 to 10 milligrams by kilo. So that means a very high volume for the nasal mucosa. So we're trying to see if using those highest volume with highest dose can work for a child with laceration. So we're about to end the project. We had another patient recruited yesterday. So we're missing just 3 patients. So we should have some results in January or February to show you better. Because most of the studies using intranasal ketamine were done by a dentist prior to this, so not a lot of on a procedural that we are doing in the emergency department, let's say. So I think we need to have a little bit more literature to use this broadly.
Yeah, I agree wholly with Evelyn. I'll add to that intranasal ketamine, we use it in 2 different ways, mainly in acute care. One is a subdissociative lower dose for pain management, and the second is a higher dose in that 5 to 10 milligrams per kilogram range for sedation. So there's 2 different indications with 2 different dosings. The greatest problem, as Evelyn has highlighted, is that the volumes get very big very fast. And currently the higher concentration ketamine that we would need to make this effective and practical rather is not available in Canada readily. So until that problem is resolved, we're somewhat limited in how much we can use it. When we've compared intranasal ketamine to intranasal fentanyl head-to-head, and I'm using the royal we, our research group hasn't done it, it's other groups like Frey, for instance, who've done it. It has the similar effects for analgesia, but more adverse events, so more dizziness, more nausea. So it's something to think about. It's a tool in your toolkit, but it's not the great replacement for intranasal fentanyl at this time. And there's a large 6-center, 500-patient study that will be starting in the new year here in Canada for children, looking at intranasal ketamine and combining it with dexmedetomidine, which some of you may be familiar with as well, to try to temper that issue of not having to use to try to avoid very large volumes of ketamine, which make it extremely uncomfortable for children if they need 8 or 10 sprays, for instance. Nobody likes that. Yeah.
It just,
sorry.
Sorry, go ahead. Go ahead.
I just wanted to complete for the intranasal ketamine the dose of sedation. Just to let you know, the dose that we are using at the moment for laceration repair in our research project is 6 milligrams by kilo. So, and mainly it's for a younger child. So at this point, this seems to be interesting because the volume are not too high using the 6 milligram by kilo dose, but we will see with the result next month if it's enough effective.
Continuing on that conversation of intranasal medications, we have a question from someone who says they're a general pediatric nurse on the ward and they use intranasal midazolam and fentanyl for procedures, but many of the children have distress from this due to complaints about pain in the nasal cavity. She's just wondering if this is a common complaint that you have seen, and do you have any suggestions on how to decrease that?
In the literature, what is reported is that intranasal midazolam is very uncomfortable on administration. It's more the midazolam that have that side effect than the intranasal fentanyl, with much more less uncomfortable to be used. For some have do a spray of lidocaine prior to use intranasal midazolam.
All right, and Samina, don't hesitate to jump in, of course, if you have anything to add to any of these.
Of course, I would just say that if you were going to use both, I'd probably start fentanyl first, just for the analgesic effect to some degree before giving the more painful midazolam.
Question about EMLA. Well, just asking, what topical agent would you normally recommend for immunizations? So this person's suggesting that EMLA takes up to 30 minutes to be effective and not ideal for an appointment, like an influenza immunization for which they only book 15 minutes.
Yeah.
Well, let's go. I'm going to let you talk, Samina.
Sure. With EMLA, it's actually recommended 60 minutes application time. And then for the shorter acting ones, minimum 20, more like 30. So truthfully, if you are trying to promote that in a clinic where there's rapid turnover, the ideal way to do that would probably involve empowering the families to get it before they come to the appointment. In many provinces, Alberta included, you can buy topical anesthetics without a prescription at the pharmacy. It's held behind the counter, but you just have to ask for it. And you can cover it with a Tegaderm if you have that. And if you don't, saran wrap or plastic wrap and tape works just as well. And tell the families to put that on before they come in. But that involves a lot of sort of preventative public health engagement to have people know that before they show up. If you're using it for blood work, IVs, this kind of thing in our emergency setting, many of the pediatric emergency hospitals across Canada have nurse-initiated protocols to have it applied at triage, so that if the nurse at triage is anticipating that they will need blood work or an IV, they slap it right on, right at the beginning, apply it, and then by the time the blood work is ordered, it's already been 30 to 60 minutes. But you're absolutely right. It is a challenge. If you have very short appointments, they have to have applied it ahead of time.
All right. Next question's asking about For any of the things you've talked about, whether it's EMLA or any of the things you presented, any suggestions related to adaptations to procedures for children with sensory impairments, either visual or hearing loss? Is there anything that's known to work or not work with children that have those kinds of sensory impairments?
So this is Evelyn. Go ahead, please. Yeah.
Yes, I did read something specifically, but I can have a look on child that have visual impairment. But one thing that I've noticed into practice in some children with autism or with developmental delay, we did use the pain ease on some of them, preparing them of the coolness of the spray prior, and had success with it. It's not something that I read, but it's something that I saw on some patients. And for some of them, we introduced recently in our hospital nurse administration of nitrous oxide for patients that have needle phobia or that are very distressed by some needle procedure, and we had some great success using the nitrous oxide as well for those patients that can be more distressed, and we needed less to restrain those child that had a previous very difficult experience with a needle or with some other painful procedure. So now, do you have something that you want to add of something you read in the literature?
I will just mention that this is a real a sore point in the sense that we don't have a lot of evidence for children who are have specific special needs, whether they're sensory neural or on the autism spectrum, for instance. This is an area where we're really lacking more developmental delay. So this is an area that we need to get better at and provide more robust evidence. For now, based on review of what we see out there, is the things Evelyn had said for sure, plus engaging the parents, asking them what works for your child. The caregivers, they know better than anyone what the best circumstances would be to minimize distress for their child. So of course, that's always our hope that we would engage parents, but in this scenario, more than ever, I would like to make an effort and make sure that was done.
That's absolutely something that SKIP is interested in. We have lots of members from the rehab community that are participating in SKIP. Holland Bloorview Kids Rehabilitation Hospital being one of the larger ones in Toronto, are very interested in managing pain in children with neurodevelopmental disorders, autism, etc. So yeah, definitely an issue there. We actually have some content at the workshop that we're doing in partnership with CFHI at the Children's Healthcare Canada Conference. One of the practices that will be presented there is about exactly this issue in children with autism, and making accommodations for things like sensory issues that they might have and triggers, and pain-related issues that they might have when dealing with procedures or other medical issues. So if you're interested in that area, be sure to come to our conference and sign up for the CFHI workshop. So we do have just a couple minutes left. We have two more quick questions. I think they'll be fairly quick questions. So if you do have, we might be able to squeeze one more in. If you do have a question that you'd like to ask, go ahead and type it in, and we'll try and get to it before we sign off at 12 o'clock. But the next question, and maybe we can start with you, Evelyn, on this one. Do you have any recommendations for mass vaccination? So for example, children in school, where you're vaccinating large numbers of children at once, where needle phobia is a big problem and attention to pain and anxiety is very low. And I can attest to that. My children just went through their vaccinations at school, and they talked about my kids are pretty okay because I had them prepared, but they talked about what seemed like carnage in line as children are crying and everything else in school. But do you have any recommendations for that?
And each year when it's vaccination time, we see those patients that have been faint in the school and that are brought to our emergency. So I think you're totally true. For those mass vaccination, we should do more for those kids. That can be sometimes distressing, their friend fainting after their vaccination. I think it will be quite easy to have a pre-written order for the nurse that do the vaccination in school, to have pre-written order to use topical anesthetic. And it will be definitely very easy to have some distraction tool using tablets, so they can listen to music, look at video. That could be things that they could have their toolbox with some distraction strategy that could be included in some. I know that some schools, they put some film on screen on the screens while the kids are getting vaccinated, to try to distract them. I think it was an interesting tool that my daughter's school used last year as well. So I think what we're doing for blood draw in the emergency can be quite easily applicable in those mass vaccinations.
I was just asking you a question, Samina, and I had my own microphone on mute, so you probably didn't hear that. I was just thinking for that mass vaccination piece, I was thinking about Anna Tadio's card system. I think it's one of the tools that's listed in the Children's Healthcare Canada toolkit, but she developed that set of cards where children can pick from a deck of different distraction tools or whatever, and when they get up to the line, they can hand these cards to the person, and then they're aware of what they want to do to help themselves manage the pain, whether it's listen to music or whatever it is. Anything else to suggest, Samina?
No, that's that the card was the one thing that came to mind as well. And this is an area that I think Skip is interested in, and we've been here at the Western Hub have been exploring this locally a little bit to see if we can build up some momentum and find some people who are willing to take this on with us, because it is whoever had posed the question is absolutely right. This is a huge public health implication. And one thing that I will mention is that Dr. Tadio's system does also suggest that if you pre-screen and there is someone who's got very high anxiety and stress about it, is pull them out. Don't vaccinate them at school, because there is that mass, we build up, we feed off of each other's emotions. So that child you want to create a much safer environment for, and not have the opportunity for that anxiety to be passed on to the other children who were coping reasonably.
Yeah. All right. And Dr. Anna Tadio is at Sick Kids and University of Toronto. If you're looking, if it's not on our toolkit listed on our Knowledge Exchange Network, you can find her at by searching for her name, Anna Tadio, and at Sick Kids. The last question we have, and I will start this one with Evelyn. Maybe you know of this. Someone's just asking if there's any news on the Buzzy or the J-tip, and if they'll be approved in Canada. Apparently, I'm not familiar with these. Maybe you guys are.
Yes, we talked a little bit about it in the statement. Sylvie Lemay did a great study using the Buzzy with her student Ariane in Saint Justine, and it seems to be a device that is quite interesting, but it's unfortunately not available yet in Canada. It didn't have been. It didn't have the Health Canada approval except for the research project at this time. I just looked recently, and it's not approved yet. And it is the same thing with the J-tips study that has been done. It's available in the US, but not in Canada at this point.
All right, and with that, I think we have all of the questions exhausted. A great list of questions. Thank you for all the great answers. I mean, it was just an excellent discussion at the end here. So before we sign off, I just want to give each of you just a chance for any closing comments or key messages, or what's coming next, or new research that you might be producing that people can look forward to. Anything that's coming up, we'll just give you a chance for any final statements before we sign off. Evelyn, we can start with you.
I would say thank you. Thanks a lot for giving us this opportunity to presenting today and to talk about the statement that we work for so long on it. I really hope that people can use it in their different department hospitals to improve it. But I'm sure that Skip will do a great job in helping people to use those strategy. I think that's where we are now. We know what to do, we know what to use, but we need to use it, even if we're very busy in our care. As Tamina said, doing it will help us saving time for the next kids visit. So it was a pleasure to be with you today.
Very much for that. And Samina, anything from you before we sign off? Any exciting new activities that you want to mention that the Western Hub's doing, or anything else you want to sign off with?
No, I think that Evelyn that was a great note to finish up on, and we'll keep you all in the loop with the Skip newsletter if you sign up at the website. Yeah.
That's the website kidsinpain.ca, and the newsletter is called In the Loop. And I think there's a link right on the front page, right at the top. So if you just click that, you can sign up for the Skip newsletter, so you can find out all the great things that are going to be happening there. So with that, I think we'll wrap up. Again, thanks for a great presentation. Thanks to the Canadian Pediatric Society for supporting this work, and for both of you, Dr. Trottier and Dr. Ali, for leading this presentation, along with all of the other co-authors that were listed there. We did just have a question about whether the session's recorded. We do these webinars every Wednesday at 11 a.m. Eastern Time, but we do record them. So if you can't watch them, we do record them and make them available on the Knowledge Exchange Network at ken.children'shealthcarecanada.ca. But when you do get to watch live, your questions and comments really enrich the discussion. So we always encourage you to watch live, but of course, when you can't, we do record these sessions. This is actually the last webinar for a little while. We're taking our conference is at a weird time this year. It's normally in October. Because of the election this year, we moved it to December. So we actually take a break around the conference, and we take a break over the Christmas and New Year's break. So we're actually going to be going on hiatus after this until the new year. So if you want to know when our next webinar is, I encourage you to sign up for the Children's Healthcare Canada Spark newsletter, and you can sign up for that right on our website at children'shealthcarecanada.ca, and that lets you know when the next webinars are, when the recordings are available, and all sorts of other activities that Children's Healthcare Canada is doing. So thanks again to the Canadian Pediatric Society for bringing this work for us today. Thanks to our presenters and to all of you for joining us, and hopefully we'll either see you at the conference in person, perhaps in Ottawa here, or if not, hopefully we'll see you in the new year at our next webinar. Bye, everyone.